So the topic is recent advances in radiotherapy for prostate cancer. We had to prepone this session due to some logistic issues. May I request Dr. Sham Sundar C to come over the dais and start the session. May I request Dr. Tanvir Shahid sir and Dr. Proshanjit Chatterjee sir to come over the dais to chair the session.
Yeah.
So we are thankful to Dr. Sham for agreeing with for such a short notice. So let's start the lecture, Recent Advances in Radiotherapy of Prostate Cancer.
Yeah. Good afternoon, everyone. I'm not sure if I'll justify recent advances. I'll try to try recent updates and let's see what's in the horizon in the radiotherapy of prostate cancer in the near future. So this is what I'll be dealing with. I'll see what is there in the horizon in fractionation. Where are we at dose selection and what are we looking at? How is image guidance and delivery, what is there and how we can improve, and what's happening in the post-operative radiotherapy setting. So coming to fractionation. So now we are shifting from moderate to extreme. So after the results of the POP-RT has come, we are more or less treating, all of us are treating with moderate hypofractionation, and it is now considered a standard of care. We can see that between the whole pelvic and the other additional thing that came up with prostate POP-RT trial is that it showed a significant benefit with inclusion of whole pelvic radiotherapy in patients with high-risk prostate cancer. We also have to remember that the patients with high risk were also at risk of having 20% chance of nodal risk as per the Roche formula. So this is the results of POP-RT. Then where are we heading now? So we are now heading towards SBRT in high-risk prostate cancer, which is basically finishing off the treatment in about 5 sittings. So there are several studies in this which have been reported. Most of them have given 7 to 8 gray in 5 fractions over a period of 2 weeks. And the last being that is from the Tata Memorial Group in India. But the studies that I had shown here have not treated with pelvic lymph nodes. So the initial 2 studies that treated with pelvic lymph nodes are the Saturn and the FASTR trials. The FASTR trials was early terminated because of increased GI and GU toxicities, whereas the Saturn trial did show some promising results. It showed that the acute toxicities and the late toxicities and the prevalence of GI and GU toxicities were kind of similar. So this led to numerous phase 3 trials in high-risk prostate cancer, and in the hypofractionated RT in prostate cancer. Most of them were in the low risk and intermediate risk setting. Then came the PRIME trial, where we are comparing high risk and very high risk prostate cancer patients to receive 36.25 gray in 5 fractions over 2 weeks to the prostate and 25 in 5 to the nodes, versus moderate hypofractionated radiotherapy, which is basically the POP-RT regimen in patients with high-risk prostate cancer. So what is the need for this study? So now that moderate hypofractionation has become standard, there is growing interest in role of extreme hypofractionation. Several single-arm studies have shown to be safe in prostate-only RT, whereas the SBAT data in patients requiring pelvic lymph node radiation is rare. Thereby, this study could throw in some light in this area. So this is the study design. So when this was happening, they also published a retrospective comparison of 220 patients at TMC, Tata Memorial Hospital, Mumbai, receiving prostate-only SBRT versus whole pelvic SBRT in about 100 patients comparative. And with a median follow-up of 28 months, they reported the acute urinary, and then gastrointestinal, as well as the late toxicities. They found that there was a trend towards increase in acute GI and late GU toxicities among these patients. And in a multivariate analysis, it showed that the volume of irradiation did influence them. So so at this point in terms of fractionation, extreme hypofractionated RT in high-risk prostate cancer patients for prostate and pelvic nodal RT, the prime trial, probably that's the next thing that we are going to look at. Then what's happening with the extreme hypofractionation in the intermediate and low-risk setting? So there are several single-arm studies as well as comparative studies reporting large patient numbers and with relatively longer follow-up data showing safety and efficacy of extreme hypofractionated radiation therapy. And then this, I just picked it up because this came a few months back, and it's an update from ASTRO 2023 on the PACE-B trial. In the PACE-B trial, there are 3 arms in PACE, PACE A, B, and C. I'm going to look at only PACE-B. PACE-B had 2 arms, either conventional fractionated radiation therapy, which could be either 78 gray in 39 fractions or a moderate hypofractionation of 62 in 20 fractions compared against 36.25 in 5 fractions. A total of 874 patients, essentially low risk or maybe favorable intermediate risk because most of them have not received ADT. They were randomized to conventional or moderate hypofractionation versus the extreme hypofractionated arm where the CTV received a 40 gray boost as well. And if you look at the endpoint that they have reported, there is no difference in terms of biochemical progression-free survival. And the other thing to note is that a good proportion of patients were treated with moderate hypofractionation regime as well. Like around 300 patients in the comparator arm were treated with 62 in 20 fractions. So, and the toxicity reports, if you see, the grade 1 on the grade 2 toxicities in terms of GI as well as GU were comparable in between both these arms. So to summarize, biochemical and clinical failure rates were low in PACE-B. SBRT administered at 35 gray in 5 fractions is non-inferior to conventional radiotherapy or with moderate hypofractionated radiation therapy. Toxicity is low in both the arms. SBRT is more convenient and more cost-effective. And probably this is level 1 evidence that SBRT should be considered as a new standard of care in low and intermediate risk prostate cancer. So what next in fractionation? So here we can see that we started with about 2 gray per fraction and we are treating for about 8 weeks. Then we started treating about 3 gray per fraction where the treatment time came down to 4. 8 gray per fraction we are treating about 2 weeks. Then if you treat about 13 gray per fraction, you could probably treat in about a week with 2 fractions. And now we are looking at single fraction RT for in the extreme hypofractionated setting. So SBRT versus brachytherapy in less than 5 fractions, how did it fare? So this is an emerging area of emerging interest. There is good evidence to support 2 to 4 fractions of brachytherapy as supported by the NCCN guidelines. Today morning also we saw some data showing that brachytherapy yields good results in this setting. And early results have been observed in SBRT schedules in 2 to 4 settings as well. However, if we have to look at single fraction using HDR brachytherapy, results have shown to be suboptimal. So we have to await long-term SBRT series data to look at what can progress in this. So this is a relatively older study which was published between comparing 2 arms of 5 fractions SBRT versus single dose SBRT, and the outcomes as well as the toxicities were similar between both the groups. So now coming to dose escalation. So till now we were all, whenever we saw trials comparing normal 70 gray dose versus 80 gray dose escalated arm, we were not talking about an overall survival advantage. Whereas the recent update which has come just a couple of days back from the GETEC AFU 18 randomized trial, around 505 patients from 25 French centers were treated with either 80 gray RT versus 70 gray RT with long-term androgen deprivation therapy. The other dose escalation trials, most of them did not have long-term ADT. Probably they had slightly lower duration of ADT. Here the median duration of ADT was almost 3 years. And in this trial, we can see that there was an overall survival advantage in the dose escalated arm compared to the 70 gray arm. So this is another level 1 evidence which has come up now, showing that long-term ADT along with dose escalated RT should be the standard of care in high-risk prostate cancer. However, these trials have started many years back, so now we have evolved in terms of fractionation schemes and those have changed. So we will have to see what dose we will have to end up with moderate hypofractionated setting as well. So how much do we dose escalate to? Now we have reached 80 and we have said that 80 is better than 70. So do we see that if we give 100, will it become more? Or is there a plateauing of dose response? And is there a role for focal dose escalation compared to whole gland dose escalation? So then came the FLAME trial, where in this study where they have compared the conventional fractionated radiotherapy and a focal dose escalation to the dominant intraprostatic lesion. So basically they have given 77 and 35 to the whole prostate and an EQD2 of 115, yielding up to 95 gray SAB to the DIL. So this is focal dose escalation, which is in FLAME trial. This was also a randomized trial, and we can see that that the biochemical disease-free survival was better in the focal boost arm compared to the conventional fractionated arm. And if you see in greater detail, the patients who have received 90 to 95 gray have a lower risk of biochemical failure compared to patients receiving a lower dose in the focal DIL. So some patients also received lower dose in the DIL. The reason is because the adjacent organ of risk constraints are not met. So in this trial design, when they studied, the organ of risk constraints were the first priority, and if the organ of risk constraints are met, then the maximum dose that could be delivered to the DIL was used. So therefore this observation was noted, and the late GU and GI toxicities were not significant in between the two arms. So where are we in focal dose escalation? We have the FLAME. There are other trials which are coming up, HypoFlame, which is about 5 fractions, 1 fraction per week, again with the focal boost, and then HypoFlame 2.0, which is 5 fractions over 2 weeks with a focal boost. So we are probably marching into this, where we are trying to dose escalate only to the into the GTV than to the entire gland. Then coming to the next advances where I'm looking at image guidance and delivery. So let's talk about MR-Linac. So we know that because of the presence of rectum and the urinary bladder, the prostate is definitely under continuous motion, and as well as the organs around it, the bladder and the rectum can also fill, and that also can cause significant motion, which could cause both those perturbations in the target and the organ at risk. So in the era where we are using higher margins, MR-Linac could help in reducing margins. What are the limitations of the conventional IGRT? So there is poor resolution of the cone beam CT scans. Real-time monitoring is not available. And if we put fiducials and we track them, we can't take the organ at risk motion into account. And then most of us still use 5 mm margins for treating SBRT settings as well. So in the MR-Linac, there is Cine-MR, in which the real-time image guidance is there. Intrafraction, there will be an MR which will be acquired, and then possibly there will be a gate window in which the treatment will be delivered. When the threshold is beyond that, the treatment would stop. So this was a phase 3 randomized study, the Mirage trial, which had compared CT-guided SBRT versus MR-guided SBRT, and the acute grade 2 side effects were lesser in the MR-guided SBRT arm compared to the CT-guided SBRT arm. So throwing some more light into this, so what they did was the time of the prostate, the fraction of the time prostate was in the gating window as defined as gating duty cycle. Basically what happens is when the Cine-MR is taken, if the prostate is there within the window, the treatment would be delivered. If it's moving outside the window, then the treatment would not be delivered. So this was averaged out, and they calculated the time in which the prostate would be there as the gating duty cycle. An ideal gating duty cycle would be 1, but in this analysis of the Mirage trial, the median was around 0.974, and in about 60% of patients, for at least one fraction, the GDC was less than 0.9, and about 30% of patients in the GDC was around 0.8. In patients with larger displacement from the ideal value, there was more frequent GU toxicities. So better image guidance, better motion management is likely to reduce toxicities in future. So how do we stop this motion? So we at our center with protons, we do not have the provision of having any intrafraction treatment guidance. So we use a rectal balloon. When we use a rectal balloon and then fill with a fixed amount of water on a daily basis, the rectal balloon firmly wedges the prostate in between the pubic symphysis and the rectum, and the prostate does not move. So this could help in reducing your volumes and also giving crisper margins posteriorly. Next is spaces. This is another thing that we can look at. You inject a space OAR in the space between the prostate and the rectum. This was discussed in the morning in the brachytherapy session. And it has also been shown to reduce the incidence of rectal toxicity as well as some preservant better sexual function in these patients. Then finally coming to post-operative settings, the radicals RT, the final results of this trial were out recently. Basically around 1396 patients were given RT either immediately post in the adjuvant setting or in the salvage setting. And the freedom-free from biochemical disease failure as well as the progression-free survival and the overall survival between the adjuvant and the salvage arms were not significantly different. With 80 events, the freedom from distant metastasis was 93% in the adjuvant RT arm versus 90% in the early salvage RT group. A corresponding 10-year survival was all not so different between the two groups. So probably we are moving away from doing any adjuvant RT, and we are going to likely treat patients with only salvage RT from now on. That's where we are heading in. Already we are doing that. We'll be completely moving away from adjuvant RT in the next few years. So to summarize, in fractionation, we saw that the PACE-B trial established strong evidence supporting SBRT in low and intermediate risk. Moderate hypofractionation with pelvic lymph nodes is standard of care in high-risk disease, and the results of PRIME trial are awaited, wherein we can try extreme hypofractionation in high-risk prostate cancer patients. Then coming to dose escalation, we saw that there was the first time an overall survival benefit was demonstrated in a phase 3 randomized trial with dose escalation. And we are moving into focal boost, dose escalation, and flame. Probably it could be the way forward. Then in image guidance, MR-Linac has really been a game changer. It helps in real-time monitoring and gated treatment delivery. The other option in the absence of these options could be rectal balloon and spaces. And in post-operative radiotherapy, radical RT demonstrate no benefit with adjuvant RT. So salvage RT is likely to be a way forward. So I conclude with this. Thank you. So greetings from Apollo Proton Cancer Center. That's our entire team. I work with Dr. Srinivas Chilkuri, who leads our team. Acknowledgements team.
Thank you so much, Dr. Sham. As usual, it was a very crisp and excellent presentation.
Thank you.
So do we have any questions? Dr. Indranil is here. Any inputs? No? So if not, can I ask you one thing?
Sure, please.
We do understand that moderate hypofractionation has become the standard of care as of now. PRIME, we are waiting for the results. What about in the post-op setting? You did cover that, but regarding the fractionation, are we thinking something?
So we are moving into the radical RT scheme where we are going to give 52.5 in 20 fractions. We are moving towards that as well, sir. Even in the post-operative setting, we are looking at moderate hypofractionation.
Indradil, as your protocol in hypofractionation, what is your fractionation schedule in post-op setting?
We started a few years back, and our fractionation is 55 in 20, kind of to match a 64, 65 gray dose level. I still don't understand the 52.5 calculation. So that is what we've been using for several years now. So yeah, I mean, hypofractionation is entirely possible in the post-operative setting as well. But I think we need more trials and more, analyses of the radicals paper, etc., to see whether it is appropriate. But I see no problem. I mean, you can follow the radicals 52.5 in 20 in the post-operative setting when you are doing early salvage. But when you're not doing early salvage and you want to hypofractionate, then I think 52.5 in 20 is a little low.
Especially if there is
yeah.
avid disease there, then
Yeah.
that would not.
Fine. Thank you so much, Dr. Sham. Thank you.
Thank you, sir.